Yeah. So my topic of presentation is DMEC performed for failed penetrating keratoplastic grafts, visual outcomes, and graft survival. So penetrating keratoplastic grafts failing due to endothelial decompensation, we have option of performing a repeat full thickness PK with a repeat cascade of multiple sutures and astigmatism, or perform endothelial keratoplasty technique like DSEC with faster rehabilitation and lesser ocular surface problems. DMEC has now become the standard of care for any endothelial failure, and Price et al. Were first to report excellent short-term outcomes in short series. However, there is no single study evaluating the long-term outcomes of DMEC for failed PKs. So this brings us to the purpose of the study, which was to evaluate the long-term outcomes of and survival of DMEC for failed PKs and the principal risk factors for graft failure. This was a retrospective review of consecutive 93 DMEC cases performed by 2 experienced surgeons for failed PKs between May 2010 and Feb 2018 at Price Vision Group, Indianapolis. A standardized surgical technique using a scuba technique was used for the donor preparation. The DMEC graft diameter depended on the diameter of the initial failed PK and the recipient graft white to white diameter. Coming to the technique of donor insertion, in case of prior to the donor insertion, that the Descemet membrane of the failed PK was stripped in all cases so as to achieve donor attachment, avoiding the graft host junction and staying well within the edge of the PK wound. Inferior peripheral iridotomy was performed to avoid a pupillary block, and then the donor was injected using a 2.2 to 2.8 millimeter IOL injector. Once the donor orientation, when the graft was opened and the donor orientation was assessed, a full air chamber airfill was left at the end of the case. In 10 cases, the DMEC was combined with phacoemulsification procedure. The patients were assessed for preoperative risk factors for graft failure and also assessed postoperatively for at regular intervals. And complications were documented for purpose of graft failure and graft rejection were defined as per the cornea preservation time study. The descriptive statistics were reported as the median and interquartile range. The differences between the p-value between the pre-op and the post-op pachymetry were compared using the paired t test, and estimated probability of graft survival was measured using the Kaplan-Meier graft survival and log rank test. A 5% significance level was considered. 93 DMEC cases performed in 84 eyes of 77 patients were assessed for 21 months, a median of 21 months ranging from 2 months to 7 years. The primary indication was optical rehabilitation in 80 eyes. The pre-existing conditions include the glaucoma tube shunt in 2 eyes, trabeculectomy in 10 eyes, and corneal neovascularization in 13 eyes. 80% eyes had a single failed prior PK, while 20% eyes had more than one failed prior PK. Coming to the DMEC graft diameter, 8 millimeter was the most common size in 70% eyes, and 9 millimeter graft was used in 20 eyes. This made that 37% eyes had an undersized DMEC graft as compared to the initial failed PK. 28% had same size, and 35% the DMEC donor size exceeded. Coming to the results, the visual acuity of 2040 was achieved at 3 months from the median of 2000 preoperative, and was which improved to 2030 at 6 months and was maintained at 2030 at 1 year. There was a corresponding decrease in the postoperative pachymetry, and the endothelial cell loss was 31% to baseline at 6 months, 44% at 1 year, and was maintained at 47% at 2 years. The most common complication was air re-injection, and which was up to 39% eyes required for partial graft detachment. Interestingly, 25% eyes required 2 or more air injections. We saw that 53% eyes, as compared to the other eyes, required air re-injection when the graft was oversized relative to the prior failed PK. Coming to the graft failures, 5 eyes had early graft failure, 10 eyes had a late graft failure. The eyes which had late graft failure predominantly had tubes, had prior trabs or tubes and complex intersegment pathologies. Interestingly, the rejection rate was only 1.7% through 2 years. Only 2 eyes in the series had a graft rejection. This is the Kaplan-Meier graph survival, in which we can see as compared to the prior eyes which didn't had any trab or tube. The eyes with prior tube or trab had a significantly higher risk of graft failure. So what the study adds, the median visual acuity of 2040 at 3 months with DMEC was significantly better than 2050 with DSEC for a failed PK. This is a very interesting OCT in which we can see right eye of the patient underwent DSEC, which improved to 2040, whereas eye with DMEC for a failed PK improved to 2025. So there is significantly reduced risk of graft rejection, and however there is increased likelihood of air re-injection, and patients need to be appropriately counseled for it. And eyes with tube surgery had a higher risk of graft failure with DMEC after PK. So this brings us to conclusion that the treatment of failed PK with DMEC produced better visual outcomes with lower risk of graft rejection episodes and a similar 4-year graft survival rate as compared to the visual outcomes produced with the previous DSEC or a PK or a repeat PK. Thank you.